Good morning, everyone. My name is Heather Hare. I'm the executive director for the Emergency Strategic Clinical Network, and I want to welcome you here in Calgary, across Alberta, and also across Canada. Several emergency departments are joining us this morning. I want to take the opportunity to start this presentation by acknowledging our land. So we would like to acknowledge that we are gathered today on Treaty 7 in Métis Region 3 territory, a traditional meeting place of the Blackfoot and the people of the Treaty 7 region in southern Alberta, which includes Siksika, the Pictina, the Kayan, the Tsuut'ina, and the Stoney Nakoda First Nations. The city of Calgary is also home to Métis Nation of Alberta Regional 3. So without further ado, I'd like to welcome Dr. Eddie Lang to the podium to introduce our speaker. Thank you.
Thank you, Heather, and good morning to everyone who's gathered here today, as well as the extensive network of people who are logging in virtually across the country. This is incredibly exciting. It's a national webinar, the largest of its kind that I've ever seen, and a big congratulations to Heather and Layla and the Emergency Strategic Clinical Network for putting this on. So my name is Eddie Lang. I'm the Zone Clinical Department Head here in Calgary and also the Scientific Director for the Emergency Strategic Clinical Network. And I have the distinct pleasure this morning of introducing our guest speaker, Dr. Gail D'Onofrio, who is here with us from Yale University and New Haven, Connecticut. And I could go on forever about Gail's accomplishments. Suffice it to say that she is just a stellar international academic, having secured millions and millions of dollars of NIH grant funding, publications, and has been incredibly generous with her time, both in launching academic careers and serving as a mentor, and in being generous enough to be here with us in Calgary. But what is often the case is that some of the most interesting things about the introduction often come from the dinner the night before. So what we learned last night when we were able to take Gail out for dinner is that she was almost a trauma surgeon. She was one of those hotshot, slick surgeons who loved to plug holes, loved procedures, and was on a career trajectory for trauma surgery before she, well, I don't want to say saw the light, but ended up coming to be currently the professor and chair of emergency medicine at Yale University. And I think what we learned last night is that although Gail loved to plug bullet holes, she realized that the underlying problem in so many of these sad trauma cases and the carnage that we continue to see is largely the result of substance use disorder. And that's, I hope I'm not stealing any thunder, but that's what has led her down this incredible career path of advocacy and attention to science that has advanced the field. In fact, I think one of the best ways to think about Dr. D'Onofrio is that she's a trailblazer. She has taken the management of substance use disorder and placed it firmly inside of the emergency department at our directly in front of us on our radar, when that certainly wasn't the case and would not be the case if it wasn't for the great work that she's done. So without further ado, please join me in welcoming Dr. D'Onofrio to Calgary and to Canada for this webinar.
So thank you, everyone. Thank you for having me here. It is my passion to kind of spread the word around how one can deal with opiate use disorder, and particularly emergency medicine. Okay. I'll do it this way. So these are my disclosures. I am funded by many agencies in the United States, and Aetna had offered to film the one video that you are seeing. So for emergency medicine, as you all know, we are the 24/7, 365-day option for us to fight this opiate crisis. I always start really all of my talks by making sure people understand really the phases of addiction so that we know that we are dealing with real people and real problems. So throughout Canada, there are obviously many people who have lost their lives, but these are a few Andrew Gallagher, British Columbia, accidental overdose. Stephen Howell from Alberta, fentanyl overdose. Stephanie Vermeer, Manitoba, fentanyl poisoning. Alexandra Sanderson, Manitoba, fentanyl overdose. So the number of opiate-related deaths in 2017 here in the country of Canada, every day, more than 11 people lose their lives. In the entire country, again, just a very short period of time from 2016, January to March, which is the most recent data that you all have, 8,000 people lost their lives to opiate use disorder. And as you know, as in the US and everywhere, fentanyl has really taken over, and so that the deaths are rising and rising from fentanyl as opposed to other opiates that are involved. This becomes obviously, as you know, a real problem. Many people don't even know they're using fentanyl. It's obviously much more potent, and it's easy to just lose your life with one use. Every time a patient leaves and uses is an opportunity for them to die. So we need to use that opportunity to engage them in treatment and know there is no other place than us who can do that better than those people who visit the ED. So I always think it's important that we think about the science of addiction, because no matter who I speak to, whether it's lay people or physicians, no matter what, people don't really understand the disease. If you understand a little bit about the disease, you'll know more. So about why this disease happens. It's a very complex disease. It really has a lot of many biological and genetic risk factors that are involved for the initiation and progression of this disease. It's characterized by a compulsive behavior. And this behavior is seeking drugs no matter what and using them. Even knowing that the adverse effect will be death, it doesn't matter. It's a continual cycle. It causes these incredible functional circuit deficits in the brain that I'll try to talk to you about just briefly so that you can kind of get it, but it's all about loss of control. And it doesn't really matter how, as I said, how much you know that you will die, it will continually happen, and it will continually, we will lose the ability for judgment and control even after you stop using the drug. So how does this happen? It all happens in the reward systems, which are mediated by dopamine. However, these reward systems are really important. They keep us alive. So individually, we stay alive because we eat. Eating is very rewarding. We have sex to propagate the species. It's very rewarding. If we didn't have this, we wouldn't propagate the species. So that these are very ingrained in our brain and very functional. So how is that kind of hijacked in this particular evidence? For some reason, when certain people use drugs, they get a major reward from using that drug. Not everybody does, but some people do, and that's where the genetics come into play. It is primarily mediated by dopamine, but we do know that in the brains of people that have used and have addictions to opioids as well as animals, that in fact that dopamine is reduced so that they have downregulation of that dopamine, but they still have the compulsive activity and the motivation to use drugs. That is primarily because of the fact that they have conditioning. That conditioning can be anything from the friends that they use with, from the place that they use with, from the drug paraphernalia. So that continual conditioning allows them to continue to want the drug. They will use that drug no matter what. So this whole system that really revolves about stress, revolves around and dopamine and involving in reward system also affects our prefrontal lobe. And dopamine has a lot of influence in our executive function. This is how we think about things, how we were able to have self-regulation and self-control. And so with disruption of this, you get all the things that one understands about addiction, which is really that total loss of control. So even if you think that you can tell somebody they will die, if I could put some drug right there and say, if you use that, you will die, they will use it. So if you understand that, they have to use it. It's just within their neurobiology. You understand addiction. This is just a simple PET scan so that you can see these are looking at people who had cocaine addictions, and you can see if you showed people with addictions with cocaine that their amygdala and part of this limbic system would not light up when you showed them nature videos. However, if you showed them a cocaine video so that there was cocaine around it, that amygdala will be activated. It doesn't matter if they're in a period where they're in treatment and they're not using. No matter what, if I sit you down there and I do a PET scan, if you've had an addiction to cocaine or opiates, this will light up, even if I show you paraphernalia that's related to it. So it doesn't really matter if you stop using, this will continue. We don't really know how long this continues, but we think it's a very, very long time. Thus, it's a chronic relapsing disease. Thus, it is not a moral failing. So thinking that this is a failing or there's some reason that people could stop is erroneous and will lead you down the wrong path in terms of treatment. So what is addiction? First of all, we know that there is a big interplay between chronic disease, experimental use, and opiate use disorder. Not everybody who uses opiates for chronic pain, not everybody who has experimental use will go on and have an opiate use disorder. It is really a combination of all these factors and a big genetic factor that can do it. This is the DSM criteria for an opiate use disorder, and all of this, really we don't have to go over it individually, but what it shows you is the loss of control. That they're going to need more, they'll do it, they'll give up their friends, they'll give up their jobs, they'll ignore their spouses, their children, their parents, whatever it is, there's a driving force about it. What to note here is not associated just with addiction is tolerance and withdrawal. Everybody who uses opiates for chronic pain, for cancer, whatever, who's prescribed opiates in the correct way, sickle cell disease, will develop a tolerance to opiates and they will withdraw from opiates. That does not mean they have an addiction. So you cannot really just count these two over here because everyone who uses chronic opiates. It's that cycle, as I told you, of loss of control that really accentuates addiction and characterizes. So what does it feel like to have an addiction? At first, when people use drugs, particularly these heroin or fentanyl, they will get a very big high very quickly. But that, as I said, as the brain becomes used to it and it adapts to it, their dopamine receptors are downregulated, they will need to use more and more drug to get that high. So it's very unlikely that people are really getting high, but they are really trying to not feel sick. So as they're using, they're trying to get into this place where they don't feel as bad as they are in those cycles. So what are effective treatments for opiate use disorder? We have called them, and many people call them, medication-assisted treatment. I really hate that word, and many of us do. So if we're going to be stuck with this MAT, let's talk about medication for addiction treatment. And the reason I say that is because in diabetes, for example, we know that insulin is the treatment of choice. We don't call it insulin, assisted treatment is whatever. It's the treatment is insulin. There are many behavioral things around diabetes that one needs to talk about. Dietary reasons, weight control, etc. Good eye care, good foot care. But we don't talk about that as the medication-assisted insulin. So the same is true of opiate use disorder. There are many behavioral things that need to be worked out with this disease. However, there are medications that can treat it. These are the three medications that we have so far: methadone, buprenorphine, and naltrexone. What is not considered evidence-based treatment is detoxification, abstinence-oriented therapy, mutual support groups, or handing out naloxone. All right, these are not treatment. Some may be harm reduction. Some may lead to death. So if you understand what I talked about, how addiction happens, and a little bit about the neurobiology, you can understand how terrible it is for detoxification or abstinence-based programs. People can send their children away and really mortgage their arms off and their homes to pay for that. And what happens? Nothing happens. They lose their tolerance, and therefore the minute they step out of that environment, they will die the first time they use. The circuits have not changed. So it'll all be there, those cues and that downregulation and that wantingness and the disruption of those executive functions are still there. So the minute they walk out, they have the potential to use again. And now when they use, they will die. So many options for ED providers at first. We could not, and in the US and here, you need to be a specialist to give out methadone. With us, you need an opiate treatment program. But with the initiation of buprenorphine in the early 2000s, we were able to prescribe it and use it. So that you understand a little bit about how these medications work in the brain. You can see the intrinsic activity of each. So most of you know about methadone. Methadone is a full agonist. And so the more that you give, the more activity it has, the more effect it has. And as you know, you can give more and more and more till the person stops breathing and they're dead. And that's it. The antagonist is something that will actually sit on that receptor site and allow it not to work. And that's the naloxone that we use to reversal. It's also naltrexone, which is another medication. Similarly, that is an antagonist to all of these receptors, which are primarily mu receptors. Buprenorphine is a little bit different. It's a partial agonist. So what that means is up to a certain dose that it sits on that receptor site and it works. But it reaches a threshold. And beyond that, nothing more will happen. And so it makes it a very, very safe medication. Even if you give it to a child, if a child picks it up off of a table or something, it is reportable if they were to die. All right, they will go to sleep, but they will not die because at some point it will stop. Also, the other things to know, as we'll talk about throughout the questions, are that buprenorphine has much higher affinity to those receptors than any other opioid. So what it will do is it will displace anything that is on the mu receptor off, and it will go on so it can precipitate withdrawal. So if I just took some methadone, then I take a Suboxone or a buprenorphine pill, what will happen is it will displace the methadone off of those receptors. I'll have a lot of freedom right there, and I will start to get into horrific withdrawal. So what is buprenorphine? Here it is. It's a semi-synthetic drug derivative. It's 25 to 50 times more potent than morphine. It is the partial agonist. It is often combined with naloxone in a 1-to-4 relationship. So if you give 8 milligrams, you give 2 milligrams of naloxone is combined. It is bioavailability of the buprenorphine is best by sublingual. It doesn't have much bioavailability through the GI tract, so that's why we give it sublingually. The naloxone has very little bioavailability sublingually, more if you ingest it or if you take the pill and heat it up and try to inject it. So that's why the naloxone is really as a way to prevent using it in different forms that were not intended to be used. It has many formulations. There's a 1-month Sublocade out now, a 1-month injection, and hopefully by the end of this year, this calendar year, Braeburn will put out a 7-day injection as well. And you can use it with or without naloxone. Generally in pregnancy, we will use it without naloxone, but depends on where you are. The thing to know about this, these again are all these receptors, sites in the brain, and that you need to give enough buprenorphine to saturate those receptors. If you give a small amount of buprenorphine, then individuals will still crave and will go out and use. So this was from Mark Greenwald's work in Michigan, and he showed that these are all these possible receptor sites from PET, and as you go up the chain here and giving more and more buprenorphine, you saturate all of those sites. So that the worst thing you can do is give too little, you need to give too much. You almost can't give too much because if you understand again that the curve I showed you, that you will reach a certain limit. It's also why everyone will not benefit from buprenorphine, because if you're using a tremendous amount of drug, you may need a higher amount and you won't get that way from here, so you may need to go switch to methadone. So it's not for everybody, but it's something that we can give in the emergency department. And just because we initiate it in the emergency department doesn't mean that as you get to your referral sites and your addiction specialists that they may not change people to other agonists, but it's what we can to get them there. And this is what it feels like when you're taking an opiate agonist medication. It feels like you're stable. It just feels like you're normal. It doesn't feel like you're high or you're low. You're just stable throughout the day. Therefore, you can go on and really work on your life. It's not simply replacing one drug for another. It is not a drug, it is a medication. We give it as physicians, we give a certain amount of it over a certain period of course of time, and it has a very specific mode of action. What do we know about it? We know from multiple studies that does lots of things, and this is all opiate agonist treatment. It has a reduction in illicit substance use. There's less viral transmissions of HIV and other IV drug complications. There's reduction in the risk of overdose deaths. there's a reduction in legal consequences, and people have more time to have sustaining relationships, gain faithful employment, and deal with their other medical problems. Now, I understand you don't have naltrexone in Canada, which is fortunate and unfortunate at the same time. Naltrexone is a medication that is helpful for some people. I like to call it similar to antabuse in alcohol problems. There are very few people that use antabuse, but particularly people who are very well motivated for their alcohol use disorder, and those tend to be people in professions, nurses, doctors, etc. It works quite well. Naltrexone is a total antagonist, pure antagonist. So it would require that the individual who has an opiate use disorder be detoxed for 7 to 10 days in your normal traditional cocktails, which don't really work. And then it can be taken in a pill or a Vivitrol, which is a monthly injection. It's not an easy injection. It's 3 cc's in the buttocks, which is quite a lot. It's quite expensive in American dollars. It's somewhere between $1,200 and $1,400. I think we're going to wait. Go ahead.
The pill form is available in Canada.
Okay, thank you. Thank you very much. The pill form is available. The problem with the pill form is people don't take it because you have to take it every day. So, but thank you. So the pill form is available. It's, I guess, not used as much. The only thing I would like to tell you is that we have put out these papers, and one is from Europe and Norway. One is from published in Lancet, but is from investigators in the U.S. And what I do want to tell you is that they say that both these medications were equally safe and effective from buprenorphine and comparing it, but it is not. And if you read the articles, you will find out that there is incredible flaws in these articles. So particularly in the XBOT study that was done with individuals who were, first of all, inpatient detox. They all had to be detoxified after opiate use disorder in an inpatient environment. We know that the treatment of opiate use disorder is outpatient. We need much more chairs than we need beds. All right, that's the treatment of opiate use disorder. Unless you're homeless or have other problems, then we do need to have wraparound services, but you don't need to be in a hospitalized setting. Again, we know here that 25% of the people that were randomized to the Vivitrol arm didn't even take it because they refused to take the injection. So they started with 25% less. They then did their analysis on their protocol as opposed to intention to treat. So it was erroneous, that finding. The same was true in the other study that was done here, the study that was published in JAMA Psychiatry. People were given tiny doses of buprenorphine. They had to go in every day to get it, and the other patients were given the injection. So again, we're comparing apples and oranges. There absolutely is nothing that says that naltrexone is better than opiate agonists. For now, we have opiate agonist treatment, and we do have naltrexone. It is something that should be available because there are some people that can use it, but it's a tiny amount of people. There's overwhelming evidence, and I don't probably need to tell most of you about this, but there's overwhelming evidence that opiate agonist treatment works, and that is, let's see if I can go forward in this, sorry, and that is even here in France, as we saw, as buprenorphine and methadone were instituted here, the death rate plummeted down, and you can see that buprenorphine came in around this area, so as more opiate agonists were given, the death rate came plummeting down. In Baltimore, where the other first studies were done with buprenorphine, again, what we saw was that the heroin overdoses, which were in red, consistently went down as we started buprenorphine, which again here was about in 2002. So as buprenorphine went up and methadone continued and also escalated, the deaths dropped tremendously. There have been major Cochrane reviews, and you can go look at those Cochrane reviews. One in 2014 by Maddox showed you that methadone and buprenorphine were equally effective if the buprenorphine was given in the adequate doses, because originally it was not given in adequate doses. We also saw in another Cochrane review in 2011 that in fact that the medication worked, and regardless of psychosocial supports. So the medication is the backbone of the treatment of opiate use disorder. Does it mean that you shouldn't have therapy? I'm not saying that. I'm just saying that you need the medication. Another couple of studies that I think are really interesting, they both use these Kaplan-Meier curves. Keiko was one of the first people in Lancet that reported this in Sweden. They took 40 patients, 20 of them, they gave buprenorphine and they detoxed them with the buprenorphine over a few days. The other 20 they put on consistent buprenorphine for a year. In this circumstance, what you can see is that all the people who detoxed here off of the buprenorphine, none of them were in treatment at the end of the year. When you look at the people who were given the continual buprenorphine, 75% of them were in treatment at 1 year. And most importantly, 4 of these people in the control group died. None of the people died in the buprenorphine group. So if you fast forward, see how here we are very recently, Mark La Rochelle, if you haven't read this article, this is a fabulous article to read from Massachusetts. What he did was he was able to look at over 17,000 patients who had had an overdose within the last year in Massachusetts. And he was able to link a whole bunch of data sets together, which I can't do in my state of Connecticut, but they can in Massachusetts. And what he found is that almost 5%, this is the top thing, almost 5% of patients were dead after 1 year when they were seen in the emergency department. If in fact they had used any opiate agonist such as buprenorphine or methadone, which are these groups here, they had a much less cause mortality, reduced it almost by 60%. Right? Only though, unfortunately, a third of patients had received buprenorphine who had gone to an ED or wherever when they had their overdose. But they clearly saw that opiate-related deaths and all-cause mortality plummeted when they were put on opiate agonist treatment. Those people that were on naltrexone, however, had no reduce in mortality. And that may be because there are not that many people on naltrexone, but it really did not show any reduce in mortality. So why the ED? Why are we here? Because that's where the patients are. Okay? We're here, that's why people rob banks, right? Because that's where the money is. We're here in the ED because that's where the patients are. So we did this original study of randomized controlled trial looking at patients who had come in with, at that time, what we called opiate dependence or severe to moderate opiate use disorder. We randomized patients into 3 different groups because we really didn't understand what would be the best way of doing this. One group was referral. This is much more than most people did because we actually took into consideration the patient's preference, their insurance status, and we gave them exactly where they should go. And that was the referral group, much more than was traditionally done. This middle group is what we had done already. We had given a brief intervention, which is a very brief using motivational techniques of why people should want to engage in treatment and a conversation. Over than that, we did a facilitated referral, meaning because of your insurance, because of your wishes, we're going to get you here. We called the place. If they were open, we may provide transportation, things like that. And the last group was we still did that motivational conversation, but we also initiated buprenorphine. Half those people got it at the time they were there because they were withdrawing enough. Half the time people got it as a take-home with instructions. And we found, much to our surprise, and people went to our primary care center where Dr. Feline actually was their doctor for 10 weeks of treatment. And what we found was that people were 2 times more likely to be engaged in formal addiction treatment at 30 days than if they had used these others. This is not bad, either of them, but it's not really what's done in real life in most places. But this was twice as better. We also found that their 7-day use of illicit drugs was much less. So they were using less than 1 time a day versus 2 times a day in the other groups. And that's something to remember, that people are not going to be abstinent initially, we talked about that cycle and that circuit. They are not. To think that they're going to be totally abstinent is kind of ridiculous. So you can expect that. And so when you have urines that have opiates in them, it requires an escalation of care and treatment. It does not require de-escalation or firing anybody. So we concluded that buprenorphine with follow-up and primary care was superior than referral and brief intervention in engaging people in treatment and reducing their days of illicit use. And it also reduced, by the way, inpatient use because all these people were being done as outpatient. And our economist at Yale, Dr. Susan Bush, actually published this, which is really hard to understand from my point of view or anybody's, of how cost-effectiveness trials are done. But she was able to show that these cost-effective acceptability curves, that both the willingness to pay any percentage point increase was better for buprenorphine than it was in the other groups, and the willingness for anyone to pay for one additional day free of opiates was better with buprenorphine and more cost effective. So this 22-year-old comes to your ED in a private vehicle. This is their real patients. They're pulled out. The staff takes them out of the car, drags them out, gives them naloxone, and then they tell us that 2 weeks prior they switched from buprenorphine to IV heroin. So why is this different than any other emergency? What do we need to do? Okay, so I think we need to be more explicit here in step 2, and so I'm going to tell you what to do. All right, so we have these, and this is all online, and I can share any of it with you. NIDA has graciously put it up on their website. This is pretty much this integrated pathway, and one of those is really how do you define people? Like how do you find their ED presentations? And most emergency physicians are very hung up on this. They'll just say, and nurses, I don't really want to screen all these people. Well, how about you just take the people that are hitting you in the face, okay? Because most of them are just hitting you in the face. They come in, they're seeking treatment, they have obvious complications, they're withdrawing, they're overdose, they have a skin infection. So start with them, I always say, before you start feeling like you have to do this big, wide screening protocol, because that sort of makes people stop there and say, we do all this screening, now you want us to do one more thing. So I say, well, why don't we just start with the things that hit us in the face? And also during the course of a visit, you may elicit other information that shows you that people have an opiate use disorder. However, there are many tools out there. This is the TAPS tool that NIDA touts here, and it's part of a whole group of things that ask about tobacco. It asks the 2 questions for alcohol, and it asks. There's no easy way to ask about opiates, right? It's illegal. You can't just go up to say with someone. They're not going to just readily divulge this. If they didn't want to tell you, write a triage. All right. So to go through these things is more difficult. Do you take any of these, pain medications or these narcotics, or do you take any heroin? Do you take all this and blah, 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 blah. But they're there if you want them. Okay. Now, when we assess, there's really important things that you need to know about buprenorphine. You need to know that the person has an opiate use disorder, right? Because as I told you, people will come in who are using it for chronic pain. People will come in who have experimented. In one little study we just did, Dr. Hawk from Yale really did this study looking at 24 patients with overdose, which he did focused qualitative interviews. And out of those, a quarter of them did not meet opiate use disorder. So people may be experimenting, people may think they've used cocaine, and in fact, they used fentanyl. Any kind of combinations of drugs they may have used may have been tainted by an opioid. You do not want to start them on an opioid. Right? So you want to make sure that they do meet opiate use criteria. It's not hard to do. I've only had to do this once or twice in my whole life, go through this, because most people are obvious I'm injecting, right? And you also want to know that they're withdrawing. This is the other thing that you can get in trouble with, is if they're not withdrawing, then you don't want to start treating them, because I said if they're not withdrawing and there's something there on their mu receptors, you will displace it, and they will start to have precipitated withdrawal, which we can talk about. I have never created precipitated withdrawal, ever. I have been doing this for 10 years. All right, I have seen it once for someone who came in from the outside, and I talk all the time with investigators and also treatment providers throughout the country, and it's always because they haven't done the COW score, right, and haven't realized that people were on methadone, which is very long acting. So I will talk to you more about that. So how do you motivate patients to take treatment? You will see some of this in the video. We've published this a lot. It's something very simple. It's just a way of conversation with people. You can't walk up to them and just say to you, okay, so you almost died. Are you ready now? That will not work. Trust me. All right. So if you raise the subject, if you would just say, do you mind if we talk about it? If you give them some concern, if you say, I want to, most people, and even doing focus groups with people with addictions, they think that we don't really care about them. We want to get them the heck out of there. You don't know anything about it, and they can be quite specific in that language about how we don't know anything, and most of the time they're right. So you can say to them, I'm worried about you, I'm concerned about you, and I'd like to talk about it. Some of the ways of creating that conversation are asking them, and you don't always have to do this, but you want to open the conversation. So we ask them, how ready are you to change something? You can do this for anything. You can do this with your family, you can do this with your friends, not specifically, but are you ready to do something? Sort of, yeah. So you pick a number. Tell me why you didn't pick a larger number. So give me reasons why you think it's important to change, or tell me what it is. And really, in a matter of seconds, people will tell you, I've lost my family, I've lost my job. It's not hard to elicit this information, whether it's from alcohol, cocaine, whatever it is. So now we're going to see this short video about talking to someone. Hi, Mr. Coleman. I'm Dr. D'Onofrio. I'm going to be taking care of you today. So do you mind if I spend a few minutes talking to you about your heroin use?
Whatever.
So it seems like you were brought in by ambulance after a friend called 911. Do you remember any of that?
Yeah, a little bit. I don't really know what happened.
So I guess they gave you some naloxone, which is the reversal for an opiate overdose, or looks like you were taking some heroin.
Yep. I just know that my girlfriend brought me here, and I woke up here, and I'm just... she called 911, and then she just left. And I just got out of this 3-week rehab program. I'm supposedly off everything, and I guess that didn't work out so well.
Well, I'm not surprised now that you told me that, because when you're in rehab and not using, your body becomes less tolerant. And actually, that's one of the biggest risks of overdoses, being in a rehab. Addiction causes all this kind of rewiring in your brain. And when it's rewired, it doesn't get back as quickly as possible. So that I'm not surprised that you started craving and using more heroin, and that you ended up here today.
Yeah, look, I guess I gotta get out of here. I'm just starting to feel like crap.
Yeah, I can see that you're starting to withdraw, but do you see some relationship or any connection between your use and being here?
Yeah, I get it, but I know what to do now.
Okay, I'm really afraid that you might overdose again. And so that you know, it has really nothing to do with your willpower, and has nothing to do with your ability to try to control it totally by yourself. I have some medication that's called buprenorphine, often known as Suboxone, that may help you with some of this. Are you willing to at least consider using some?
I don't know. I thought about doing that, but decided against it because it's really just replacing one drug for another. And I just got a new job, and I'm just not trying to go through all this again.
Well, I understand how you could think that, but it is really a medication that's been proven to be very effective to stop this withdrawal and craving. And it's like insulin for diabetics. But I can see that you are really, really in severe withdrawal. How about I just give you a little bit of the buprenorphine now? Then we can have this conversation in about a half hour.
All right.
Would you consider that?
Yeah.
Okay.
If I try some treatment, everyone will be less upset with me, and it's worth a try.
Okay, great. Have you used any long-acting drugs like methadone or OxyContin or anything like that, or just the heroin?
Just the heroin. I've tried some of that other stuff, but since I'm out, I've just been using heroin.
Then I'm going to bring the nurse in, and we're going to give you some, and you're going to feel a lot better. Then I think we'll be better able to continue the conversation, okay?
All right. That
All right,
sounds
good. I'll be back in a minute, and she'll be right in. Mr. Coleman, you look a lot better. Do you feel more comfortable?
Yeah, I do. Thank you.
Okay, so I'd want to continue this conversation, and so what are you thinking? You look like you'd be a great candidate for this because the medication really did work. On a scale of 1 to 10, 1 being totally not ready and 10 being ready to start treatment with buprenorphine, where do you think you fit in that?
I guess a 7. I don't know. I mean, I do feel better. It would be worth a shot.
Okay, great. So you're 70% ready. That's really fantastic. What are some reasons why you didn't choose a lower number? So you must have reasons that you want to change.
I mean, I do feel better, and you could be right. It might be a good fit for me, and I just feel like I've let everyone down, and I just want to make a change. So
I think that you didn't let everyone down, where it's not unexpected that people don't do well trying the first time, and I suspect that this is really a great opportunity for you to get back on track again. So it would be less cravings, less withdrawal, and pretty much let you get on with your life.
Yeah, I mean, that all sounds good.
And I'm going to refer you to one of our treatment providers who's an addiction specialist here in New Haven. You live in New Haven, correct?
Mm-hmm.
Okay, good. So I can set you up for an appointment probably on Friday morning at 9 if that works for you.
Sure.
Okay, and I'm going to give you a little bit more medication of the buprenorphine now that I know that the first worked and you didn't have any complications from it. So I'm going to give you a little bit more before you leave. Is that okay with you?
Yeah, that's fine.
All right. And the other really important thing is that I'm going to have the nurse come in and talk to you about this Narcan or naloxone kit. We really like you to learn how to use it, and so your friends and family can also learn how to use it in case you get into another overdose situation. So I'm going to have the nurse talk to you about that. She's going to give you a little bit more medication, and she's going to give you a direct appointment for Friday morning at 9 o'clock to get more follow-up. All right? And we're going to follow up to make sure that you got to that appointment okay.
All right, that sounds good. Thank you.
Okay, great. I'm really glad that you made this decision.
All right.
Take care. You can see that it seems a little bit stilted to you, but we actually audio tape all of our interventions, whether they were done for alcohol or they're done for opioids during all of this process and in our training. And I have listened to thousands of them from residents. All of our residents are trained, all of our advanced practice practitioners are trained, all of our faculty are trained. And you cannot believe how quickly people will come forward with things that you would never think that they would, and how it's done within a very brief period of time. And I may never convince you of that, but I've listened to so many of them and give feedback to people that it's really pretty impressive. And if you talk to patients, they'll say that nobody really treats them. They think that, they're just there seeking more drugs. And as many of them said, if I want drugs, I could go down the street and get tons of drugs. I don't have to sit here for 5 hours worrying about that. I can just get them. So they're not really there to get that. So as part of this treatment protocol, you've learned how to maybe talk to people, but then how to treat people. And we have these algorithms, and we can talk about these in detail later. But the most important thing is to know that the person is in moderate to opiate, has a diagnosis of moderate to severe opiate use disorder. You'd also need to assess that they haven't taken methadone within the last 72 hours to initiate it right there. Most people will tell you the truth. We actually don't do urines to show this, but people really do tell you the truth if they're using it because they understand about buprenorphine. They know that they're going to go into withdrawal if they take it, and so we want to be careful. If a person has overdosed and they come to the ED, we'd like it to be 2 hours after that naloxone dose so that you can then see where the person is. Most of those patients will get take-homes with us, meaning I don't mean they get the medication because we're not allowed to give it. They get a prescription to be filled for home induction or unobserved.
So if you've precipitated their withdrawal with Narcan,
yes.
then you evaluate their
about 2 hours after.
2 hours.
About 2 hours post that, yes. So if they're in the ED, you all are able to administer, so it's very exciting in Canada. You don't need to do all these 8 hours of training that we do, which becomes a big deal for some reason, but it shouldn't be, but it is. So if you're able to use it, if a person comes in mild withdrawal, and that is usually like somewhere between 0 and 7, we actually suggest that in that case you give them unobserved home induction. If they come in and they're 8 or more, you can dose them. If they're on the low end of that, so they're 8 and you're nervous, you can always give them 4 milligrams to start. If they're on the higher end, like 12 milligrams, 13, just give 8 milligrams. You're just wasting more time. And a lot of emergency physicians will say, I don't want to keep these patients in the ED forever. You can do this very quickly. You will have a response in 20 minutes. It's miraculous. When I first started doing this, nobody even knew what buprenorphine was. Nobody knew what I was doing, and they'd go around and say, how did you do that? I want to figure out how you did that, because now you can have a conversation with someone who was before very belligerent, very aggressive, really at risk for the nurses to be hurt. So they saw it right away. So again, if it's 12, 13, I would give 8 right away. If it's less and you're unsure, you can always give 4 and give 4 more. But you do need to give adequate amounts. If you don't give adequate amounts, there'll be lots of craving and people will go out and use again. So in general, we give 8 milligrams for people that are really withdrawing, and then we give them prescriptions for 16 milligrams a day. We give it in a one-time dose. And our instructions, which I think we have here somewhere, our instructions will show that you could give at least up to 12 milligrams in the first day. People have asked me what are the side effects of buprenorphine. They're not, they're mild, they happen early, and they often are resolved. The obvious worst case scenario is precipitated withdrawal. If you do this right, this should not happen. I'll give you some hints of how to deal with that, but really it should not happen. Our dosing, as I said, is somewhere initially when you hand it to the patient, 4 to 8 milligrams, depending on their CAL score. Giving too little, you might as well not have given it. If you don't start saturating, as I showed you with that PET scan, you might as well not have given it. They're going to go out and they're going to use. Our maximum dose we suggest for the first day is around 12 milligrams. But there are other investigators who are giving huge amounts. I'm just telling you, and we're trying to study it right now, and they've done fine with it. This is just what we know and what we are suggesting. This is very different than even SAMHSA's guidelines for in the US, which are small amounts, 2 milligrams here, 2 milligrams there. So we don't do that. We give them at least 8 or 12 for the first day overall, and then we give them 16 milligrams a day until we can get them to a referral site. And then there are discharge. We have a form. Any ED should have some kind of form, and you send that form to wherever you refer them. You fax it. If it's electronic, you send it electronically. We have about 5 sites that we send people to. So we have these specific things in these sites. So I know that if I send somebody to one of our federally funded health centers, they will take people every day before 10 o'clock. Another one of my opiate treatment programs will take anybody before 11. Another person only takes people 3 times a week. So that's there. I give them a specific time, and then I send this form, again, either electronically or to fax to that place saying, I saw this patient, I gave them this much buprenorphine, and they're going to see you at such and such a day, and then we call to make sure that they got there. These are our take-home home instructions. We spent months working on this, and with a graphic artist, so you want to tell the person they need to feel very sick from the withdrawal. They all know what that withdrawal sign is. They should have at least 3 of these symptoms, and it should be at least this amount of time after they have used their drug. And if they feel like they should take it, they should wait another 30 minutes, right? And then when they're really feeling badly, they can start. And we usually have them start with 4 milligrams because they're doing this at home by themselves. We just say to them, okay, if you didn't get significantly worse, remember, they may not be improved on 4, but they didn't get worse. So if they don't get worse, they take another 4, all right? And so if they take 4 and they can wait some more time, they can even take another 4 if they want for a maximum of 12 for that day. And then they take 16 milligrams each day afterwards. And this is all on the website, and you can download this, and everyone can have any of this. So, and then we also, in my hospital, provide this specific Narcan spray. This is not true of everywhere. People get prescriptions. It depends on here if they're free, and you can go, I understand you can get them anywhere. So there's no excuse for doing some harm reduction strategies. And there are many people who, and there are videos online for people who will just tell you, I don't want anything. And then you can do the harm reduction. Don't use alone. You're luckier than we are that you have consumption sites and everything. So these are all the things, and I want to wind up. These are all the things that emergency physicians can do. They can safely prescribe, they can do harm reduction techniques with naloxone, et cetera. They can start and give access. They can do advocacy for everything around your country of anything that you need, and you can reduce stigma. And one study that did come out of the United States showed that this was a data set of people with commercial insurance, but if we prescribe more than 3 days, then the likelihood that people will be on chronic opiates is pretty low. But if we prescribe for 7 days, as you can see, it goes up much significantly to 15%. And if we prescribe for a month, the 1-year probability of people being on it is over 35–40%. So we can do a great job. This was in the Morbidity and Mortality Weekly Review. And that most importantly, we have to reduce stigma. And this is for everybody. This is for patients, this is for family, this is for the public, and this is for ourselves as well, that we know that judgments are made based on certain things. and that people, individuals with opiate use disorder do not seek treatment most of the time because of the stigma that is associated with it. That the way that we as professionals talk about substance use disorder is really important to each other and to patients, and we are part of the big problem here. And as I will tell you later on, why are we not doing this? I have no idea why you're not doing it. This is evidence-based treatment. I can only say that you're not doing it because there's some stigma involved in yourselves. Because you would not do this if someone came in DKA. You would not treat somebody who came in with an MI and you'd say, I'm really sorry, we don't have the lab today. Or, I never really trained on that. I don't really know how to give TPA with stroke because, I never really did that training. I think there are some people here who did the training. Let me look around and see if there's a doctor here on today who can. Oh, maybe it's a Friday, so I can't really do that. Maybe you'll have to show up on Monday. And I'm not sure you'll actually get there because I don't know. Do you have transportation? Do you have a car? Well, I'm sorry, good luck. Here's a pamphlet. Go on with you. So it's part of our identity that we're not taking this on is what is wrong with it? What is different from this disease than any other disease that people can choose whether or not to treat it or interact with it? And I would tell you that you should avoid certain words. Again, this is all on the internet, but that you stop using the word an addict and you start saying that people have an addiction. You don't just say that diabetic in room 14, maybe sometimes you do, but we try not to do that in front of the person, right? Babies are not born addicted. That's impossible. I just told you what addiction was. It was this loss of control and doing stuff. A baby can't actually do that. So there are babies born with neonatal abstinence syndrome. We call it a disorder. It is a disease. It is an addiction. We don't have these clean and dirty urines. You don't say that with diabetes, that you have this dirty urine because it's full of sugar. You don't say that at all. We don't say that people kind of relapse as much as they return to use. They have treatment attempts. They do not have failures. And that I don't like this word of recovery, but I can't think of a better word to use, and we haven't. So if we use this is very powerful. And patients may not. They may define themselves as addicts, and I'll just say, okay, you can say that, but I'm not going to define you as that, okay? I'm defining you as this person that has a disease entity, and I'm going to take care of you with that. And so we have our patient again who comes in a life-threatening event. You have leaders all across Canada who are helping. These are some that I found out, some of the people who are here, some of the people I met last night. In particular, I love this thing when I asked them to send me pictures. Marshall sent me this Ghost Suboxone picture of himself, and I'm so excited about that. So now we have this opportunity to embrace science-based treatments, to engage other emergency physicians and change the trajectory of the opioid epidemic. And so this is something that a physician by the name of Andrew Herring has in his ED, which is in Oakland, California. And this is right there at triage. And this is what I would hope that every ED has. It says, we need to help you. You need help with pain pills or heroin. We're there to help you. So the sign is there. There's no screening involved here. The person can come in and say, ask for it. We will give you help. So that we can go back and not add to these mountains of people who are losing their lives in Canada, and we can change the way we think about addiction, the way we talk about addiction, and the way that we treat addiction. And that's it.
That was fantastic, Gail. Thanks so much. I just wanted to before we're going to take some questions here and comments here in the audience, for those tuned in online through the webinar, if you were to email a question or query to emergency.scn, that's Strategic Clinical Network, just scn @ahs.ca, we'll get that addressed if we get that in on time.
Great. How about here, questions? Here.
Yeah, any thoughts, comments from the audience? Colleen?
I'm just wondering how you started doing this. You said you've been doing it for 10 years. How did it come to be?
So it was part of a study. So I've always been doing work with substance use disorders. And back in the middle 2000s, a RFA came out around use of interventions for drugs versus alcohol. And people started thinking about, could we use some brief intervention and treatment, engagement stuff to treat drugs? So I remember calling up the project officer and saying, I'm not going to do all drugs because that's ridiculous. You actually think I can talk to somebody who's using heroin and talk them out of using it? Or do you think that someone who's using cocaine, I can have this 5-minute intervention and stop that? I can't. So it will be different for every addiction, but I was thinking about taking a specific drug, and in this case it was opioids. And at Yale we had the people there, Dr. Filene and Dr. O'Connor, who had done the original work with buprenorphine with patients in primary care. They had done the original studies. It came out in New England Journal and JAMA, and they showed that they were effective keeping people in treatment, and that it was quite feasible to do it. So I said, what if we did that from the ED? That would be like remarkable, since most people don't go to primary care in my country, all right, especially young people. So what if we found them in the ED and we started initiating? So it was a really novel idea, and some people thought I was a little crazy of doing that, but I said, why not? And I was able to learn from these great people who had experience. So I just started doing it, and then I applied for this grant, and that's how I got it. And that's, it wasn't at the time where all of this trajectory was as bad as it was now, so it just happened to be that way, that this study had happened. But nobody had heard about it. People in my ID thought I was nuts. It was all part of then a trial, and I said, okay, I'm taking total responsibility for this. I know this is your patient, but every single patient, I had to talk to the attending, I had to talk to the nurse. Nurse says, what is this medicine that's coming up? I've never heard of this. The pharmacist was not happy about it. Like, everybody was. I said, don't worry, I'm doing it. It's going to be fine. And so every single patient, I had to go through this for a long period of time. And then they would start to see, oh my God, that medicine she gave, it was remarkable. What was that medication? And then I would try to tell them about how it had worked. And I tried to get some feedback back to people if I know that when I did it, I didn't know a part of the trial, but if I did it outside the trial or just with alcohol and any other thing, that I feed back positive results to the caregivers, that it works. Because we in the ED only see people that come back. We don't see success stories. So always it's a good idea to try and loop back and make sure that those people who have initiated something know that they did well. So it was really just, wow. So the other studies there were two major other trials, one by Rich Sates, and I'm blanking on the other gentleman's name. Both of them came out in JAMA at the same time, and they both showed that there were no efficacy of brief interventions with drugs, but they used every drug known to man, the primary one of which was cannabis. And as they started their studies, I told them, and a huge study in the U.S. called ED Smart, which again, I told them before they did it, I was someone on that committee, I said, this is going to turn out to be a negative trial, because you cannot expect that one intervention, one talking to somebody, is going to do anything, right? Not in this field. You can talk to people about engaging in treatment, but that's not going to make them, that's not treating them. That's kind of, when you're in the severe end of the spectrum of any substance use disorder, the conversation in emergency medicine is getting them to an addiction specialist or a treatment program. It's not stopping their addiction, right? There's nothing you can do about that. What you can do is help them engage in treatment. And in this particular problem with opioids, we can start a pharmacological treatment that is known to work. So we can do that, and we can engage them. It's a long answer to your question.
Any other question here? We do have a question coming from Dennis Kinneberg from the Center for Toxicology here in Alberta, whose general question is about what lab services can do to support the treatment of these patients. And also, it opens the door a little bit to the question of, do we need to get urines on these patients? I understand you don't. We're not inclined to, but there's some different thoughts on that.
So initially when I started this, first of all, part of a trial we had to. It's important. People were always interested in urine, some biological test, right? And if you read our paper, you'll see that the urines did not differ. There are about 50% people had positive urines. One would expect that because opiates are in the urine about 72 hours. So I don't know if I get a positive urine whether you've injected heroin 10 times every day or whether you used once yesterday. I have no idea. It doesn't tell us about severity and amount. So to me, urines are really not useful in the initial thing. The other thing that people, it costs a lot of money. So in your EDs, you're always wondering about how to pay, someone's paying for it. So do I need it? If a person comes in and tells me I'm injecting heroin, I don't need to verify they're injecting heroin if I believe they're injecting heroin. If there's some reason someone comes in and you're not sure, then of course do the urine and see. But most places, I don't know if you can get a test quickly for fentanyl. We just started doing it in my hospital after I'd been screaming for 5 years. So you may miss a lot because your hospital may not even look like heroin. So you're used to seeing people more of a toxidrome, which can be more difficult now as people use different types of drugs. Those toxidromes are not exactly perfect. But if I know that the person is injecting, if I feel very comfortable they have an opiate use disorder, I don't need to do a urine. Other people say, well, aren't you worried? They got benzos in the urine, they got cocaine in the urine, whatever. No, I'm not worried because in our study, 50% of people use cocaine. More than that had a benzo. I don't really care about those benzos. Will talk to them and say, we worry about the use of benzodiazepines with an opioid that I'm giving you, as in Suboxone, and we worry about that, just as we worry about if you use a lot of alcohol too. So we would hope that you would not, but quite truthfully, in real life, people are using, and we have not seen any negative. In fact, all of our government stuff came out to cite that the use of benzos were not a reason to withhold buprenorphine treatment. So I don't see it in the treatment facilities. Of course, they may under some protocol want to look at urines. I think that a urine can tell you that the care needs to be escalated because they're still using. It is an expectation that people will use. You're not going to get this totally right, and you're not going to get people stabilized for weeks. So would be unusual to have negative urines for a whole first month, but you might. The important part is that you don't get people off their treatment, that you don't take people off the treatment because you have a positive urine. You know, if you have diabetes and someone eats a piece of cake, like really, right? And they're back in your ED all the time. You don't say, well, I'm sorry, you already blew that chance. You're not getting insulin today. So I see it as one piece of the puzzle, but I see it more as needing an escalation of care. It also costs a fortune, and I don't know a lot about how patients pay, but I do know in the U.S. that companies have made fortunes growing up around doing urines. They charge, and our insurance companies don't cover the urine testing. So they may cover the treatment and seeing the doctor and for whatever treatment it is, alcohol or opiate use disorder, but they don't. So these companies have built up and they send urines every day and like it's ridiculous. And so it's just a waste of money to me. There was a question.
Good morning. Thank you very much. It was an excellent talk. My question relates to the fact that in Alberta we've just passed a policy related to harm reduction. So we're very excited about that. We're trying to roll it out. Some of us are trying to lead that work moving forward. You talked a lot about stigma. How do we move forward? What are some of your suggestions for changing culture, changing the stigma piece? Because it is tough.
It is tough.
It's really tough. And this particular policy applies to everyone across the organization, all settings, not just emergency or that kind of thing.
Right.
But it's a tough area to message.
Okay.
We've got some persons with lived experience that are giving us their stories. We're trying different strategies, but any suggestions?
If you just repeat the question.
Okay, so it was how to reduce stigma all over the place. So one is using the right language, okay, and I have these pins. I meant to put it on today, I didn't, around words matter. So we have to, if we really think it's a disease, we have to treat it like a disease, and all over the place. We need to have clear expectations of everybody that's involved. I also think that for for physicians as well as the public, these stories are very empowering. So if people can see that, look, these are not people that I think of, that's not me, that's not anybody, no, these people have some moral failing, they're like, their lives are not working, they don't really feel like working anyway. If they get to see people and hear their stories and understand that that addiction really is non-discriminatory in itself, it's across the entire board, and that we can help it across the entire board no matter what aspect people are at. And they can see that all it does is I always say, bring a patient in for the nurses, because the nurses are the hardest, right? And it's rightly so that they are hard, because they are in the ED 40 hours a week. They are seeing it. They are the ones interacting with the patient. In my institution, the doctors don't work there, mostly academics. They work a few shifts a week. They're not there. They can decompress in other ways. And they're not actually at the bedside getting all the horrific aggression. So if you could bring in a patient and show somebody, here's Sally, here's John, he's going to tell you his story and how he was able to overcome it by proper treatment, then they would be much more likely. The other thing is that no matter how much I give these talks, this is not really how you do dissemination, right? I have to find champions in each site who are willing to do this, who are willing to bring people in and let people see. I need people to start medicating people so that you can see what it looks like. I need leadership. I need the leadership in the EDs to just say, my goodness, this is the treatment, all right? I'm not asking you whether you like to do it or whether you don't like to do it. This is the evidence-based treatment. This is what we will do. And feedback, quality improvement. So okay, I can pull out of my EHR how many people came in with an overdose, how many people came in with whatever. And I look back and I see whether there is a conversation regarding anybody in that patient in treatment, whether they agreed or they didn't want to agree, and what happened. And then I go back to these people and I say, this is not okay. This is not okay. What about all the other things in EDs, right? If people return, you look at everything. We took return visits, we look at deaths, we look at anybody that from any other discipline that gives us a case. We review it ad nauseum. We go back and say whether it's preventable or if it wasn't preventable, etc. And we could data on every single physician. Well, this is what should happen here. You should go back and you should say, Dr. Jones, you had a patient, a 22-year-old came in with an overdose, and I don't see anything in this chart that you had a conversation with him, that you offered him medication, that you referred him and gave him a solid referral for the next day, or anything about that. That's malpractice, not doing that. So that should have CQI that comes back and says, what? Believe me, we do it in stroke, we do it in diabetes, we do it in anything else that emergency physicians do. And yet in this, which is killing people, every time a patient leaves there, they could die, all right? This isn't even like alcohol. You're assuming most people are not going to die from their alcohol use disorder, unless, of course, it's trauma, a motor vehicle crash. But most people will take years to die. This is a very different disease, and so it needs very, very forceful and a very strategic plan, because every time you don't do something is a risk for a death, every single time. So people ask me, are you afraid to give out Suboxone? Why, as emergency physicians, are you afraid? It is the safest medication that you give, right? You give everything. You paralyze people and hope you can intubate them, right? You give IV ketamine, you do procedures that are unbelievable, you open chests, you are risk takers all the time. Most doctors can't work in an ED because you need on very little information to act quickly and save a life. This, you can't do better than saving a life here. And you're giving a medication that you can't really hurt people as long as you know how to give it, which I just told you. If they're withdrawing and they have OUD, it's fine. All right. So what is the big disconnect here? My suggestion is the disconnect is somehow you have stigmatizing problems yourselves with this disease, because there is absolutely no reason that an emergency physician who is a risk taker by definition, who is able to learn new things every single day, can't learn how to use this life-changing medication. It's not possible.
Thanks, Gail. We've received a whole bunch of questions about the web resources that you've talked about. We're gonna collate those. We're gonna tweet them out. We're gonna put them on the Strategic Clinical Network website. A couple of questions from Brian Hallroyd, who you know from the chairs meeting. He wants to know how pregnancy fits into the picture here, as well as would you consider a thing other than methadone use a contraindication to Suboxone starts?
Okay. No, I don't. I'll start with the easiest one in terms of contraindications. No, methadone on board is something you just have to wait. So you're just going to have to give a home induction. I don't consider anything else, and I have never seen an allergy to buprenorphine. It's somehow in the literature. I've never seen an allergy to buprenorphine. In terms of pregnancy, technically, and this is just theoretically, you would want to give Subutex or without the naloxone. Most likely in your EDs, we just carry the buprenorphine because it's cheap. It's much cheaper. Suboxone is both the buprenorphine plus the naloxone. And that's what we give as prescriptions for people to take it home because of the less likelihood of diversion. In our EDs, we have just straight buprenorphine. However, even if you gave a Suboxone pill to someone who's pregnant, it's fine. You're watching them take the medication. So they're going to take it in the proper way, and they're not going to get the naloxone part of it. So pregnancy is a really good reason to want someone to start on treatment. That treatment had been methadone or buprenorphine, and buprenorphine is now approved in pregnancy. And I would think it's really important. This is the primary reason to start it. So again, people have to be withdrawing. You don't want to precipitate withdrawal, so you want to make sure they're fairly withdrawing. And then you may want to give a supervised dose. Right there, I would probably keep them a little longer in the ED. I'd want to make sure they have really careful follow-up. I recently was at another very large ED, and a provider said to me they had a patient that was pregnant. She didn't know how to do anything. She called OB. OB came down and says, oh, we can't do anything. And by the way, it's methadone only, so let her go. So it really, the physician was really struggling with that, but she didn't know what else to do. And I was doing focus groups, and if you know about focus groups, you're not really supposed to say anything, so you just listen and you hear what they say. So at the end of the focus group, and I shut off the tape recorder, I said, okay, this has got to stop. Right, that is horrible. I'm sorry you went through that because you tried. She tried everything she could possibly try, and it didn't work. So I'm going to teach you about Suboxone. Everything I can tell you right now in 5 minutes how to give this medication, just give it to her. Right, she was withdrawing, just give it to her. Don't worry about it, and then go figure out where to send her afterwards. But she was crying, she was withdrawing. It was ridiculous. So if I can tell you anyway here while you have the patient, just treat.
Two-part question. So
Sure.
in terms of the contraindication with methadone, typically how long post-methadone? So I guess you go by the COW score alone, and that will indicate the interval post.
Yes, but you want to be sure that the COW score is pretty high. So you want to make sure you're 13, 14, 15, 16. You want to be up in that range. And by historically, methadone has a very long half-life. So does buprenorphine for that matter. But so we like to say around 72 hours before, and in generally with methadone, it's going to be around 48 to more that they're going to start to withdraw because methadone has a really long half-life. They may crave, but they're not going to be in full-blown withdrawal until about day 3, and then you'd be able to give it.
So I did have a case that I think Marshall mentioned to you 2 days ago where I had precipitated withdrawal. A patient received Suboxone in the community, had been on methadone, and then presented to my site in full horrible withdrawal.
Right.
And I couldn't find a straight answer in all the resources, including the inpatient.
Of what to do with it.
What to do with that patient at that time.
Great. So the question was about precipitated withdrawal. So the first thing is not to do it because it's really hard once it happens. Okay, so that's why. And someone in a treatment program in New York just asked me about they had precipitated withdrawal, and it was really because they didn't do the COW score and they didn't ask the patient about the last methadone dose. So the first thing is to not do it, and you won't do it if you're in charge. But you will get somebody like this that you can precipitate withdrawal. The reason why you can't find anything is there isn't anything written. If you understand the pharmacology of buprenorphine that I discussed, that it will displace things off of that, so you'll have a lot of drug, now methadone, coming off and causing that. The question is, could I then give enough Suboxone to fill up those receptors and stop the withdrawal? So people have given large amounts. You can't hurt them any more than they are. So you could give them large amount of Suboxone. When I've done it once before, it was earlier in my career, and so I was very nervous, so I started give them small doses, 4 milligrams at a time every half hour, 2 to 4 milligrams. It took me a good 6 hours before it even started to work. You could also, do the cocktail of things that we know are fairly ineffective, but sometimes they work. Clonidine for the hypertension, NSAIDs, antiemetics, etc. You could do that and give them a little bit more Suboxone. Other things that people have used is sometimes people have given ketamine, and they have given that small dissociative effects, not the intubation effects that you might do in procedural sedation, and you could try that as you're giving them these other meds. None of us have a great answer because there isn't an answer. I think now I would give large doses of Suboxone.
As a single dose?
As a single dose, yeah. I'd at least start with 8. And then I'd give another 8. We do know that doctors, and Andrew is doing this, he's done at least 160 people hearing, he's given large amounts of Suboxone at one time, 32 milligrams. But again, I've not done that. I've heard people doing that, and you might consult your addiction specialist in your hospital and say, I've got this, what can I do? The best thing is to avoid it, but I'm telling you, you will not do it if you just know those same principles. If they gotta be withdrawing, if they've been on methadone, make sure they're really withdrawing and they haven't used in the last few days. And you can always start, if you're worried about the methadone, they said, yeah, I took a methadone a couple of days ago, but they're pretty withdrawing, you can start with 2 milligrams. 2 milligrams will not hurt them badly, so you can see if that worked, and then go higher.
Thanks so much, Gail. We're at the end of our time. I just wanted to apologize or let the people on the line know we've received a whole slew of questions. We're going to collate these as an FAQ list and work out the answers either with our local experts or get Gail's input. Gail, it's been fantastic to have you here. You're giving the President's, Vernon Hughes President's Lecture at noon today, which is, I think, just a feather in your cap and just shows how important the work that you're doing is. And that's helping us all and helping our patients especially. So join me in thanking you.
Let me just do one other thing. On the NIDA website, there's a frequently asked questions that I've done, and so I bet most of those questions are already answered. Okay.